Thank you, sir, for the kind introduction. So I'm going to be speaking about the role of intraocular pressure in glaucoma and the monitoring of intraocular pressure. Firstly, let us look at the definition of glaucoma. So glaucoma is defined as a chronic progressive optic neuropathy for which intraocular pressure is the only modifiable risk factor. So we should know that intraocular pressure is the only modifiable risk factor, but there are now other things also that we can change, including the ocular blood flow. But this is the definition itself. And there are many risk factors for the raised intraocular pressure, including age, which is again non-modifiable, family history, non-modifiable, ethnicity, non-modifiable, myopia, hyperopia, eye injury, and all these are non-modifiable. Then some things which we can change, that is steroid use, diabetes, obesity, hypertension, smoking, alcohol. So we have to look at what we can do to control the IOP. We also have to know how to document the intraocular pressure because it's a very dynamic thing. We have to document not only the value, we have to also document the eye, the method of measurement. Various methods of measurement are available now, and some are more accurate than others. Some are affected by some factors of the eye also. So we need to know that. We need to document the time and of course the date also of measurement, because there is a diurnal variation of intraocular pressure which we have to document. Whether the eye is dilated or undilated, whether the patient is on any anti-glaucoma medications, what they are, the last medication used, what time it was used, etc. The central corneal thickness and also the corrected IOP will be useful. So this is an example of how a complete documentation of an intraocular pressure should be. So the PGs note that these things are all important. And then we should know about the concept of target intraocular pressure. We all say that the intraocular pressure ranges from 10 to 21, and if a person is having glaucoma, we try to bring it under 21, but that is not the true fact. We have to get to an intraocular pressure that prevents further progression of the glaucomatous visual field without compromising a patient's quality of life. So sometimes we might still allow some progression of visual field loss with time. So we look at factors such as the patient's expectation of quality of life, their age, their expectation of life, their convenience, all those things to get to a target intraocular pressure. So this reason is to maintain a functional vision throughout the patient's lifetime. So glaucoma is a multifactorial management. When do we set the target IOP? We do it on the initial visit and review it periodically. So we keep monitoring the progression of various factors, the fields and the OCT, and then we have to review the target IOP, not a single one-time thing. And it has to be individualized to every person depending on all the factors. There are various studies on the importance of intraocular pressure. Of course, the ocular hypertension treatment study showed that more than 20% reduction of IOP leads to lower rate of progression in ocular hypertension patients. So even if it is not a glaucoma, if it is ocular hypertension, this 20% reduction is very important. And the CIGTA study showed that both medication and surgery are useful for reducing the intraocular pressure. Surgery more effective than the medication. And if glaucoma is treated aggressively with a lower target IOP, the glaucoma progress is very minimal. And the EMGT trial showed that for every millimeter mercury drop in intraocular pressure, there's a 10% reduction in the risk of glaucomatous progression. Advanced AGIS showed that trabeculectomy and laser trabeculoplasty can be used, and if target is set less than 18, that is what they did. Lower IOP prevents field loss. CNGTS showed in normal tension glaucoma, that is where pressure IOP is normal, 30% reduction of IOP delays progression of glaucoma. So it is still a factor in the low pressure or normal tension glaucoma as well. And there are various things which we have to note. That is a diurnal variation test. We know that there is a circadian rhythm for intraocular pressure, and the diurnal variation test, ideally taken throughout the day, will help us to identify the peaks of IOP, because some people do have a diurnal peak and some people have a nocturnal peak. But a simpler way is to do a day diurnal variation test, which picks up probably about 25% of these people also as well, where we do a diurnal variation during the clinic office hours. And this is very important in normal tension glaucoma. Water drinking test was considered a provocative test, but it is under debate. And this currently is suggested to use assess the outflow facility of the aqueous humor. And the mechanism is a choroidal expansion. Suggested explanation is this. This is you have asked the patient to abstain from food and fluid intake for 3 hours, and ask them to drink 1 liter of water within 5 minutes and check the IOP before and after 30 minutes. This actually looks at the outflow facility, and it is not truly a provocative test. Corneal thickness and IOP is another thing which is under debate. And earlier we used to always use an IOP correction nomogram. We used to take the central corneal thickness and add a correction factor or subtract from the IOP. But now it is still not a consensus, but it's suggested to use just as a separate risk factor. Monitoring intraocular pressure is very important because it is the only thing which is modifiable and measurable easily. And the gold standard is the Goldman applanation tonometer till now. So we have to try to measure with the Goldman. There are different types of tonometer, as you might have studied in your textbooks, of which Goldman and Perkins are supposed to be most accurate. And there are other easier screening tools such as the AirPuff non-contact tonometer. We also have the Shiot's tonometer, which is the indentation tonometer, which was used for several years. The Goldman tonometer comes in various types. This is the standard one, which is this is the Zeiss model, which hangs from above the microscope, and the Perkins tonometer handheld one. The rebound tonometer is a very simple and easy to use tonometer, which is suggested to have accuracy similar to the Goldman applanation tonometer in some cases, not always. And the earlier models could be used only in this vertical method, but the newer models can be used with the patient in supine position as well. So this doesn't need any topical anesthesia also, and this is a very, very useful tool. TonoPen is another tool which can be used in scarred corneas or any corneas with opacities and other things, which definitely needs proparacaine or some topical anesthetic, but it is easier to take pressures in children with these tools. Then, of course, the ocular response analyzer, which is truly an air pulse based, that is air puff based tonometer, but because it measures the complete cycle of applanation and back, it can measure the corneal hysteresis as well, which is supposed to be also important in glaucoma. So this is a better tool than our normal non-contact tonometer. And the Oculus Corvis ST also is a newer tool. Then there is the dynamic contour tonometer, which tries to get rid of some of the inaccuracies of the Goldman applanation tonometer by adapting to the cornea shape. So this adapts to the cornea shape and finds the pressure directly. Works exactly like the Goldman. Then a simpler tonometer is the diatom tonometer, which measures intraocular pressure through the eyelid. Since it touches only the eyelid and not the cornea or sclera, it is much more comfortable and easier to use, but it is not as accurate. Then home tonometry is something which is quite important if it is easily possible. Because if the pressure is measured only once in the OPD, it is not a complete picture of the patient's intraocular pressure variations. So if this sort of device, this is an eye care home model 1 and model 2, which can be used by the patient at home to measure the intraocular pressure by themselves based on the same rebound tonometer. That is, there's a ballistic probe, a metal probe, which goes and bounces on the cornea, doesn't need any topical anesthetic. And this sort of thing, if easily affordable and available, will be the future of IOP management. Then, of course, there are some newer things. There is the contact lens based tonometer, which is the Sensimed triggerfish, which is a contact lens with some strain gauge sensors. So this, once put on the patient's eye, can measure any changes in the shape and strain, and this correlates to the changes in the intraocular pressure. So once this is calibrated, it can measure the intraocular pressure by induction, electrical induction, measuring the changes in the strain and monitoring 24-hour intraocular pressure, truly 24-hour intraocular pressure. There's also one more product, an intraocular implant which goes into the anterior chamber and can measure 24-hour intraocular pressure. But these are very expensive, and this has been in several trials, and I think it is used in LV Prasad also. This one I haven't heard from recently, but these are all the newer things available. Thank you.
Thank you so much, Dr. John, for that elaborate presentation on intraocular pressure. As Dr. Manoj gets ready, I will ask two quick questions, one to John and one to Dr. Gauri. The first one to you, John. If you want to buy one more tonometer than your regular applanation tonometer, what would it be and why?
That's a very good question, sir. That's a very good question, sir. So right now, from my point of view, I will go for a rebound tonometer. The rebound tonometer, it is very convenient both for the doctor as well as the patient. The accuracy is supposed to be quite good, so that is what I would go for. But depending on your needs, you might want to go for a tono pen, or depends on what your needs as a ophthalmologist are.
My second question is to Dr. Gauri. What is your indication for a DVT? How exactly do you do it in your clinical practice? Not theory, in your clinical practice. What are your indications for DVT and how do you do it?
For a diurnal variation, firstly I would do it most of the times in the office hours. So typically we ask the patient to come in by 9 o'clock earliest, and 2 hourly readings till the clinic, the clinic hours. So sometimes I take it till 7 o'clock because the clinic is open till 8. Typically till 5 o'clock is what we take. And the second question is, when would you do it? So at the extremes of pressure, see now if there is an ocular hypertensive where I have to decide whether I will treat this patient or not, then I need to know the range of variation for this patient. So for that, typically I would say there is a patient who comes to you, pressure of 22, has a positive family history, but everything else is normal. So I want to know what his highest pressure is. I want to get an idea. So in such a situation, I would look at a diurnal variation. And the other extreme, where we have a normal tension glaucoma. So there is a patient where there is typical damage, but the pressure is like 12 or 11. So there I want to get an idea about the highest pressure and the amount of fluctuation. So that is another situation. And the third situation is where the patient is progressing despite what I think is adequate control. So that is another situation where I would do. Having said all these three situations, logistically it is not possible in all patients to do it even when it is indicated. Ideally we should do it. So in such situations, I might call them at different times of the day. So at each visit, I will tell them, do not stick with one timing for your checkup. One day you come in the morning, one day you come in the late evening. So and sometimes I ask them to come in the trough period of the drug which they are using. So typically if the patient is on a prostaglandin analog, the trough is just before they put the next drop in. So late evening, you come and get your pressures checked. So these are certain practical things that you can incorporate.
Thank you so much, Dr. Gauri.